Dr. Heather MacLean completed medical school training at Dalhousie University in 1995, having been awarded gold medalist within her graduating class. She then undertook her specialty training in neurology at the University of Ottawa, followed there by a fellowship awarded by the Canadian Network of MS Clinics and training in multiple sclerosis. She has been practicing clinical neurology with the majority of her time spent caring for patients with MS since 2001. She also has been heavily involved as a clinical investigator in many therapeutic trials ongoing at the Ottawa MS Clinic. Dr. MacLean holds an academic appointment as Assistant Professor of Medicine at the University of Ottawa, and there has taken an active role in undergraduate medical education, both in teaching and in curriculum development. She is the co-chair of the Neurosciences Education block taught at the University of Ottawa School of Medicine, and serves as unit leader for undergraduate medical school teaching in neurology, psychiatry, and ophthalmology. So welcome, Dr. Heather.
So thank you very much for that introduction. I'm pleased to see a lot of familiar faces actually in the audience. So again, I just want to welcome you to the day. Thank you very much for coming and spending the day in with us to learn, despite the fact that it's such a beautiful sunny day outside. So thank you again. Let's see if I can, there. So while this day is about the concept of exploring multiple routes to health and wellness, some of which are new and developing fields, while others are ancient practices that are being rediscovered, we would like to begin our exploration with a review of the approach that conventional medicine takes to multiple sclerosis. So what do I mean by conventional medicine? So medicine, as practiced by holders of an MD or a medical doctorate and their allied health professionals such as physiotherapists, psychologists, and nurses are considered conventional medicine. Synonyms to this would be Western medicine, mainstream medicine, orthodox medicine, biomedicine, allopathic medicine, and some people just call it allopathy. The analog to conventional medicine is alternative medicine, embracing the use of natural products and supplements, mind and body medicine, manipulative and body-based practices, and multiple others. Many prefer the term complementary medicine over alternative medicine because alternative medicine assumes that you are using these techniques instead of conventional Western medicine, while complementary medicine assumes that you are using it in conjunction with current conventional techniques. But the importance is that the boundaries between complementary medicine and conventional medicine are not absolute. And over time, the boundaries seem to be shifting and changing. And many things that we maybe consider now as complementary medicine or alternative techniques will be considered conventional in the future. So why is there an interest in complementary medicine? Well, it's because many have been confronted by the limitations of conventional medicine. Conventional medicine fails to address the needs of the whole person. It tends to reduce persons to bodily objects. We tend to dissect things and look at things under pathological specimens and do experiments on them. And while we cannot deny the tremendous therapeutic advances that this way of thinking has brought, many accuse conventional medicine as being too rational, too narrow, and in some cases, quite toxic. I might add to this, there are those with certain types of illnesses for which no conventional therapy exists that has shown any benefit. And so for those, and really all of us, there is a need for something more comprehensive. So as I mentioned, or as Amanda mentioned, I began my medical school training in 1991 and my career as an MS specialist in 2001. And I remain active in the medical school teaching and developing curriculum. And it's been very interesting to witness the evolution of thinking and approach to health throughout the years that's coming through the medical school. Through the latter half of the 19th century and the majority of the 20th century, our approach to medicine has been that of a biophysical model. And this assumes that the body is essentially a biological machine. And if there is an illness, it's because one of the machine parts has broken down or needs repair. In 1977, George Engel created a new health education and healthcare model called the biopsychosocial model. And this expanded the previous biophysical model in that it added psychology to it, okay, how our thoughts and emotions have an effect on our body, so the mind-body connection, and also how our social setting, our work, our family, stressors, coping mechanisms play a role in terms of illness and health. And just recently, in 2000, a man named King has now proposed an even new model for healthcare and health education, the biopsychosocial spiritual model. Can you imagine? And this is really a tremendous addition to our previous model, but like any models, it takes time to come into fruition. For instance, the biopsychosocial model, although it was presented first in 1977, it really probably took hold only when I was going through residency, okay, in the 1990s. So it took that long to be adopted. And then the biopsychosocial spiritual model in 2000, and I heard it for the very first time this year. And you want to know where I heard it from? A first-year medical student. So these are the group of medical students, these are the group of doctors of the future that have this mindset, and they, you know, it really is, this is the way society is moving, and this is the way medicine is moving, and it takes time to get there, but I just wanted to give you that example of this is the direction. So let's focus for the next 20 minutes, though, on the old-fashioned model. Okay, like I said, we cannot deny the advances that this approach has made possible. And so I wanted to cover a few topics in the next few minutes, just to review what is MS, as we believe it to be right now in 2011, what causes it, and how do you treat it. So what is MS? The history of MS is actually, unlike many people believe, MS is actually a new disease. Okay, it probably wasn't around in the Stone Age. We don't think it was around, you know, at the time of Jesus. We don't think it was an Egyptian thing, you know, with the pyramids. In fact, we believe, because it's an easily identifiable disorder, just basically by historical accounts, that because there's no recorded cases prior to the Middle Ages, it actually sprung up around the Middle Ages. In fact, the first case that we believe is the first possible recorded case is that of St. Ludwika von Scheidem. And she was a young girl who lived in Holland, born in 1380, and she was about 15 or 16 years old when she developed her first neurologic symptom. And it happened after an ice skating accident. She had fallen on the ice, broken some ribs, developed what sounds like an abscess over her ribs. And like many of you know, infections can produce MS attacks in those that have multiple sclerosis. She developed her first attack of paralysis shortly after this abscess had developed. And she went on to have relapses and remissions, but gradually got worse over time. And she ultimately believed that this was a disorder that was bestowed on her by God, and that it was her function to deal with the pain brought on by this disorder in order to almost like take on the pain of humanity. Okay, so she became the essence of human suffering. Okay, and she became quite a public figure, and she had quite a religious gathering around her. And ultimately, she was canonized as a saint. So she's Saint Ludwika, and she is the patron saint of skaters. But what conventional medicine has told us about MS, by dissecting and analyzing people who have had that multiple sclerosis, it has taught us what is seen in this modern photograph that's a gross specimen of a brain with advanced multiple sclerosis. And what you see, I don't know whether the pointer goes that far, but you can see a brain over there, okay? And the outside is gray matter, and it's kind of a grayish. The inside inside of the brain, just slightly inside of the gray matter, is white, and it's the white matter. And even closer to the center of that is, I wonder if I can do it on here.
Yeah.
All that shiny stuff in there, that's kind of a grayish discoloration, and it's shiny and hard, that's scar tissue, and that's the MS plaque, okay? If you were to touch a brain with your thumbs or your fingers, it's kind of mushy, like jello, okay? But if you were to touch that plaque, it would feel more like cartilage, like you'd have in a chicken, okay? It's very hard, it's shiny, it's browny discoloration, and in this case, it's quite confluent. Okay, there's a lot of MS plaque in this particular patient. And if you go even further and you take that brain and you look for myelin, which is the fatty coating of the brain, and you color the myelin with this blue dye, you can see that those spots that are white those white spots are all areas where the myelin has been denuded, okay? It's been chewed away. And if you look microscopically at those areas and how they start before they get terribly big, is every little area that has been denuded of myelin has a little blood vessel in it. And it all started as a little blood vessel, right there. Okay, that's the blood vessel. All those little purple things that are surrounding that red blood vessel are lymphocytes. Those are immune cells. Okay, and so what's happening is that the immune cells are leaving the blood circulation, entering the brain, and as they migrate out, they migrate out in a centrifugal pattern that leaves a wake of demyelinated plaque behind it. Okay, and eventually these little microscopic plaques coalesce and become macroscopic, so visible to the naked eye, plaques that you can see with the naked eye. If you look even closer, you can see that not only is there inflammation and demyelination involved in MS, but there's also damage to the nerve cells. And if you look at an area that has intact myelin, all the little purple dots there are intact axons. See the wires protruding from the nerve cells, and in a demyelinating plaque, right there's much fewer concentration of axons. So not only is there inflammation and myelin loss, but there's also a loss of nerve cells, and that's the production of disability in multiple sclerosis. So over the years since MS was first described, there's been very little that has not been postulated to cause multiple sclerosis. There have been times that we thought it was an infection, that perhaps it was a toxin. Even there were theories that had to do with body habitus, that it was only tall, thin people that got multiple sclerosis, that it was due to worry or overwork, autoimmune phenomena, and vascular and ischemic phenomena, and certainly the vascular subject is being brought up again recently. But what we think multiple sclerosis is right now, in terms of prevailing evidence in 2011, the reigning theory is that it is an autoimmune disease. So where your immune system mistakenly thinks that your central nervous system is something it should be attacking and getting rid of. So your brain and your spinal cord are under an attack by the immune system, and it causes immune-mediated damage to the myelin and to the axons within the central nervous system. So what causes it? All right, is this something that you're born with, or is this something that we've developed because we've been exposed to something in our environment? The reality is that it's probably not one or the other. It's probably a combination of both that results in the production of this disorder. So what's the evidence that this is there's a genetic link for MS? Well, certainly there's higher rates of MS in certain races. Okay, Caucasian races are more likely to get multiple sclerosis. There's higher rates of MS in families. So if you have a mother who has multiple sclerosis, you're of higher likely than the general population to develop it. And certainly in identical twins, if one identical twin gets multiple sclerosis, the other has about a 30 to 40% chance of getting it. So there definitely is a genetic impact there, but it's not 100%. And there have been a few genes that have been associated with MS, but there seems to be multiple that are involved, and we haven't identified all of them. What's the evidence that the environment is creating multiple sclerosis in us? Well, one is that there's a geographic distribution of MS. Okay, it's definitely higher towards the northern and southern hemisphere as you go farther away from the equator. There's also been some migration studies that say what happens if you move out of an endemic area into a lower prevalence area and vice versa. That tells us that there's some sort of trigger in our environment. There have been certain epidemics of MS that have risen in a certain population, like the Faroe Islands, okay? That it's sort of a sudden explosion of MS in that area that almost seems like there was something that they got exposed to and then it settled down. And lastly, there's the rising rate of MS, and we'll talk about that in a few minutes. So since 1950, it's been noticed that MS has an unusual geographic distribution varying in latitude, and we don't exactly know why this is, but as you go higher towards the northern latitude, okay, into the more temperate regions such as Canada, northern US, and northern Europe, as well as in the southern hemisphere, so we're talking about lower or southern part of Australia and New Zealand, the rates go higher. We don't know why that is, whether it's the climate, whether it's the sunlight, whether it's viruses that were affected. We're not exactly sure. There seems to be a rising incidence of multiple sclerosis. In fact, when you look at the MS statistics around the turn of the century between around 1900, about 1 in 1,000 people, 1 in 100,000 people was the incidence of MS. And over the next century, it has risen to 7 times that. Okay, but the question is it real? It certainly seems too fast for genes. It's not a genetic thing. Genes can't change that quickly. Or but maybe it's not real. Maybe we just have more MRI scanners, because we didn't have MRI before the 1980s. Maybe we have better diagnostic criteria. Maybe people are more aware of it, so they're more likely to go to their doctor. Well, results tell us that it's probably a real phenomenon because the rising rates only seems to be happening in women, okay, not in men. So over the past 60 years, MS has tripled in women and it's stayed steady in men. So we believe this is a real phenomenon. No one knows why this is. So lastly, let's talk about what treatments are currently recommended. With any therapy, you have to weigh the possible risks versus the possible benefits. And really with MS, we treat MS with a three-modal approach, a trimodal approach. One is that we tend to treat relapses, if the relapses need treatment. 2, we want to prevent relapses and delay disability. And 3, if there are chronic symptoms that are there on a day-to-day basis, we want to try and mask them or minimize them. So treating attacks right now is generally with steroids. So what do steroids do? When we give people steroids, they shorten the duration of attack. They shorten the duration that you're going to have symptoms, but they don't overall change the level of function that you're going to have 6 months and 12 months later. So there's no effect on the overall degree of recovery. And steroids do have their own side effects. You can get them either intravenously or through pills, but they are rather cumbersome to take if it's intravenously, expensive if it's intravenously. If it's pills, you have to take a lot of pills for 3 days in a row, and generally you have sort of an uncomfortable extra energy during this period. And so for mild attacks, often conservative management is just the best. How do we prevent attacks and delay disability? We have disease-modifying drugs. And while incomplete, they do help prevent relapses. They help decrease the severity of relapses, and they do help delay disability over time. There are several types of first-line disease-modifying agents. There's the beta interferons, of which there are several, including the brand names Avonex, Betaseron, Rebif, and Extavia. You should know that Extavia is actually the same molecule as Betaseron, just produced by a different company. And then there's gluteramine acetate, or also called Colpaxone, which is a polypeptide. It's like a protein-derived medication, and it has a different mode of action. And all of these work approximately the same in terms of their ability to prevent attacks and lessen the severity of the attacks. If you fail those first-line agents, there are other agents that you can move to. There's the new oral medication called Gilenya, and there is a typo here. It should read, it's a capsule that's 0.5 milligrams once daily. But there's some risks with it, okay? So we don't use it as first line. It's just become available in Canada since April. There's Tysabri, which has been out for a number of years, and it's an intravenously administered medication that's once a month. But again, there's risks with it. Okay, a 1 in 1,000 risk of developing a severe disorder of the brain called PML. Okay, so it's not insignificant. And then there's mitoxantrone, which is essentially a chemotherapy for more aggressive cases of MS, and that's given every 3 months through an infusion in an IV line. But you can't take it more than 2 years because it is quite toxic. It's toxic to the heart, and it can, in a minority of cases, actually cause cancer, ironically. Okay, so despite the slowing of the disease and the symptomatic relief that medicine has provided for some, there's still no cure. And those with multiple sclerosis still often have to cope with some level of disability, fatigue, and or pain. So recognizing the limitations of conventional medicine, we'd like to talk a little bit about complementary medicine. So the healing professions are now beginning to strive to serve the needs of patients as whole persons. And while the recommended medical therapies do address the biological mechanisms in the body, they do have limitations such as cost, side effects, and risks, and they do not address the psychosocial, spiritual aspects of the new model of wellness. So we'd like you to consider integrating other approaches to wellness within your MS treatment regime, and that's really what the rest of the day is about, exploring alternatives, exploring things to add to your treatment regime. And for those who are interested, I had read a book a number of years ago on complementary and alternative medicine in multiple sclerosis. It's by an author, Alan Bowling, and he is an American neurologist. He recognized that his patients had a tremendous interest in this, in complementary medicine, but he also wanted to approach it with an evidence-based approach. And so what he has done is he's created a book of a number of different alternative medical approaches and looked at them in terms of really what are they proposed to do, what's the likelihood that you're going to get a benefit from them versus what's the potential risk, okay? Because really, it's always weighing the benefit versus the risk, and even if the chance of a benefit is low, if there's not much risk to it, you know, maybe there might be an option at exploring this for you. This is the new version of his book, and I haven't been able to put my hands on the new version, and so he may have even more medical options in there than he did in his first series of the book, which I read many, many years ago. So for those of you who are interested, and again, welcome to the day, and from here on in, we're not going to be talking about the conventional treatments, we're going to be talking about the complementary treatments, and things for you, food for thought that you may want to explore in the future.